Well, welcome everybody. My name is Anna Cole. I'm the Director of Student and Family Services for the Roaring Fork School District. We're glad you're joining us tonight for a presentation and a little bit of Q&A with Dr. David Brooks to address the approval and then distribution of 5 to 11-year-old COVID vaccines. So again, one of our commitments as a school district is to make sure students and families have access to community resources that help ensure kids are able to learn. And so providing access to integrated health services is one of those things that we do. So tonight, Dr. Brooks from Valley View Hospital, pediatrician, chief medical officer, is joining us to talk a little bit about the COVID vaccines for 5 to 11-year-olds. And as many of you know, in the school community, through a partnership with Mountain Family Health Centers, the school district will be hosting a series of COVID vaccine clinics at our schools in the next couple of weeks, similar to what we did in the spring for older age groups. So from there, what kind of the plan for the evening is we'll have Dr. Brooks speak, and then we'll have a little bit of time where we'll open up the chat box for questions. I'll moderate those questions as long as we have time to get, to ask questions to Dr. Brooks, and then we'll wrap for the night. And thank you all for being here. Dr. Brooks, I think we'll jump over to you.
Okay, well, you can hear me okay? All right, very good. Well, I really appreciate you having me. I think this partnership between the hospital and the schools have been fantastic. So if you guys don't know me, I'm David Brooks. I'm a general pediatrician. I've been in the area for about 20 years practicing pediatrics, and I'm also the chief medical officer at Valley View Hospital, which means I've kind of helped oversee our COVID response team. And before I start talking about the vaccines, I want to take a moment and thank Anna and Rob and the entire school district. I've been very impressed with the work that they have done. I know that there's been nothing easy about this pandemic, and there's lots of different opinions out there. But I can say without any questioning that Anna, Rob, and the entire team have always put students first and foremost, and that's where their thought has always been, what is best for the students. And I also want to start by thanking you, the parents, because I know it's not been easy for you. It's been a tough year, and just by being here tonight, you're showing your commitment to your children and to the community. So I hope to have an open discussion. So I'm going to share my screen so I can get my talk up, and let's see if we can get this to work. It's always a new world. Okay. Talk up, everybody can see that?
We got it.
We got it. And can you see my mouse when I'm moving around?
Yes, we can.
Okay, because I'll use it as a pointer. So tonight we're going to talk about the COVID-19 vaccine in the 5 to 11-year-old group. And I thought about what's the best way to give this talk, and I certainly can take the position as a physician and a pediatrician and just kind of say, well, I'm the physician, you should get the vaccine, and that would be the end. But I don't think that's the best method. I certainly could make something up and say, the COVID vaccine is great, and if you get it, your kids will listen to you, clean the room, and help do the dishes. That'd probably get more people to do the vaccine. But what I want to do, and what I realize in today's day and time, is parents really need to have all the information, and they need to be informed so that they can make a decision whether this is or is not the correct answer for them and their families. So I'm going to present a fairly technical talk, the same type of talk that I might give to other physicians, but I'm going to try to make it clear and understandable. But I also want you to ask questions if you have any. So let's get started. So we're going to start, and we're going to talk about an overview of COVID-19 in children 5 to 11. We're going to talk about the incidence, how often it's happening, COVID-19 hospitalization rates. We're going to talk about multisystem inflammatory syndrome in children. We're going to talk about post-COVID conditions. We're going to talk about transmission, and then we're going to talk a little bit about the vaccine. So here's our overview, and here's what we're going to talk about. And this graph represents the current COVID-19 weekly cases per 100,000 population by age. And what you'll notice is this dark blue line here represents the 5 to 11-year-old. And what you'll see in the last few months is COVID-19 has really impacted this group. There's about 1.9 million cases of COVID-19 that have already occurred in the 5 to 11-year-old age group. This graph represents the COVID-19 hospitalizations per 100,000 in kids broken down by age group. And what you can see here is this blue line represents the 0 to 4-year-olds. As you would expect, the younger ones have higher hospitalizations from COVID-19. The green is the 12 to 17-year-olds, and the red is the 5 to 11. So fortunately, for the 5 to 11-year-old age group, hospitalizations are the lowest amongst all the age groups in children. And this is not actually too surprising. The 5 to 11-year-old group is a great group. These kids actually generally are the healthiest of all age groups beyond COVID. They actually tend to be the best behaved. They like their parents. They listen to their friends. They're actually the easiest groups. The younger ones and the older ones tend to be more challenging for many reasons. Now, when we talk about hospitalizations, we want to compare it to a common illness which we know, which is influenza. And what you see on this graph is the red, green, and blue represents the frequency of hospitalizations for influenza in 2017, 18, and 19. What you'll notice that's not on here is 2020 because we didn't have any influenza last year. The yellow line over here at the right represents the frequency of hospitalizations for COVID. And what you'll notice is that frequency is about equal to influenza. But the one thing to keep in mind is that frequency of hospitalizations occurred in a setting of intense mitigation measures like masking, social distancing, everything that we've gone through in the last year. And the expectation is if we removed all those mitigating, those other measures like masking, social distancing, the hospitalization rate for COVID would have been higher than flu. This graph compares hospitalizations for COVID to flu. And what you'll notice here is the hospitalizations was about a day longer. The ICU admissions were about 50% higher. So 21 to about 31% ended up in the ICU. And when you had flu, about 4.6 ended up on a ventilator. With COVID, it was about 7.2. Deaths were about the same between flu and COVID. Now let's talk a little bit about deaths, like I just mentioned. Now again, the 5 to 11-year-old group tends to be the lowest number of deaths for COVID in that age group, but there were about 94 deaths in this age group since the pandemic began. You'll notice it's much higher under 1 and much higher in adolescents. Now, a lot of people ask about previous COVID infections and how does that impact children? Well, they've actually been trying to track what number of kids have had COVID previously. And what they've been doing is randomly testing blood samples from a variety of commercial labs around the country. And what it shows nationally is about 38% of 5 to 11-year-olds have already had COVID. It's probably lower in Colorado and lower in our rural area. But as you can imagine, there have been a substantial number that have been tested or have already had COVID. Now, when we look at previous COVID infection in children, the difficult part is there's no good test to say whether that previous infection is a guarantee that you won't get reinfected. And what we know is that after you get infection, you're probably less likely to get COVID again for a certain time frame, but that antibody response wanes or decreases with time. And we also know that for children, they tend to have a more mild or asymptomatic case of COVID. And as a result, they get less duration and less effectiveness of that immunity. So kids, even if they've been infected, could still get infected again. Now let's take a moment and talk about multi-system inflammatory syndrome in children. Some of you may have heard about this. It's called MIS-C. And this is fairly unique to children, although it can occur on rare occasions in adults. And what this is a severe hyperinflammatory syndrome, meaning lots of inflammation that seems to occur 2 to 6 weeks after an acute COVID infection. And it results in a wide range of symptoms like heart problems, abdominal problems, fever. And this has occurred in about 1 in 3,200 cases of COVID, and about 60 to 70% of these MIS-C, which is unique to children, are admitted to the intensive care, and 1 to 2% die. So there's been about 5,217 MIS-C cases in children, and it disproportionately affects our Hispanic population. And you can also see in this graph that 5 to 11-year-old group is the highest group that's been impacted. We've all heard about long COVID, long haulers, post-COVID. These are people who get acute COVID, but then have persistent symptoms for greater than 12 weeks. And so they often have fatigue, headache, trouble sleeping, troubles concentrating, muscle, joint pain, cough. And what we know is long COVID or post-COVID is occurring in about 7 to 8% of children, regardless of the infection. And this has significant impacts on children long-term. So what about children and transmission of COVID or SARS-CoV-2? Well, we know that transmission of the SARS-CoV virus is influenced by the type of symptoms, how long you're with people, how big your viral load is, which is the alpha variant, the delta variant. But a lot of studies report similar rates of transmission from infected children as from adults. So transmission can occur from kids to adults or from adults to children. And what we know from the adults is studies have shown that vaccines decrease transmission. This is a nice example of that infectivity. And this is an example of what happened in a school when actually a teacher got infected, then other kids got infected, and they spread it to other family members and other kids. And so vaccination could be an important part of stopping this transmission. So a brief summary of COVID and what's happening in children 5 to 11. So about 1.9 million cases, about 38% of kids have already been infected. There's been about 8,300 hospitalizations. We know that the severity of hospitalization is similar to influenza. About a third of hospitalized children from 5 to 11 end up in the ICU. There's been 94 deaths in children in that age group. And I always pause for a moment to think about deaths, because if it's your child, it's either 0 deaths or 100%, and every death in a child 5 to 11 is tragic. MIS-C was most frequent in this age group we're talking about tonight. Post-COVID does occur about 7 to 8% of the time. And there's been other transmission from school-age children to other household or contacts in the family or the school. So that also is very important. Now, when we talk about this vaccine, it's important to put it in context of other diseases that we already have vaccines for. So I think this graph nicely compares the hospitalization rate per 100,000 for other diseases where we have routinely and systematically used vaccines to help keep our kids healthy. So prior to the introduction of hepatitis A, there was probably less than one hospitalization per 100,000 prior to that vaccine being implemented. What about chickenpox? Prior to that vaccine, there was about 4 to 31 hospitalizations per 100,000 prior to the vaccine, or prior to that vaccine being implemented. Influenza 30 to 80, COVID right along the lines of other vaccines. What about COVID compared to other vaccines and deaths? Well, you'll notice on this graph, it compares the average deaths per year of these other diseases when we implemented those vaccines. And the goal of this discussion is really to demonstrate that this vaccine is equally or more important than other diseases that we vaccinate for. So when we look at meningococcal disease, there was about 8 deaths per year before we implemented that vaccine. For chickenpox, there was about 16, rubella 17, rotavirus 20, and for COVID-19 in this age group, probably 66, but I mentioned earlier, it's probably 94. So this vaccine is equally, the use of it to prevent deaths is comparable to other diseases that we already vaccinate for. So let's talk about a little bit about the transmission. And if we were to vaccinate the 5 to 11-year-olds, this is expected to cause an 8% cumulative decrease in the incidence of COVID across the nation, which would decrease the number of cases by about 600,000 just over the next 5 months. And so although it may not directly impact these kids, it impacts other families, it impacts our work, and so it can have a tremendous impact on our greater community. Lastly, I want to mention that by vaccinating kids, we also decrease the total viral load that's in the community. And by decreasing the total viral load, we decrease the probability that a new variant will emerge. And so we got to keep that in the back of our minds. The more this virus circulates, the more it replicates, the more likely we're to develop a new variant that'll cause more problems. And lastly, and I think this part is really just as important, sometimes we talk about the deaths or the hospitalizations, and that's where our focus goes to. But this pandemic has had tremendous impact on kids. We've seen a significant worsening of mental or emotional health. We've doubled our number of admissions at Valley View Hospital for suicidal ideation since this pandemic has begun. There's a significant educational gap from all this interruption that has occurred to our kids' learning. And there's thoughts that this educational gap will be tough to overcome because you can't make up for lost time. There's been a decrease in physical activity and an increase in body mass index. During the pandemic, healthy kids gained an average of 3.4 pounds per year, and it used to be 2 pounds per year. May not seem a lot, but that doubling will amplify over time, and we'll see increased overweight and increased obesity, and that'll have long-term effects on kids. We've seen decreased healthcare utilizations, meaning delayed care, kids not getting their asthma medications. We've seen decreased routine immunizations. We're worried other vaccine preventable diseases will start to spike. We've had increased adverse childhood experiences just from this pandemic. And we've had a tremendous loss of caregivers. There's been about 150 to 200,000 kids nationwide that have lost a parent or a grandparent in this pandemic. So they've lost a caregiver. That's about 1 in 500 kids have lost somebody who directly cared for them. That was very important. So these things, I think, are equally important to stop this pandemic. So let's spend a few minutes talking about the vaccine for children. And so I want to go through some slides that talk about how this vaccine evolved and the evidence for its safety and how well it works. And so they did 3 phases. They did phase 1 and then a phase 2-3 session. And in phase 1, what they did is they looked at the dosing for the vaccine, and they looked at 10 micrograms, 20 micrograms, and the 30. The 30 is what's given to people over age 12. But what they determined is this 10, or 1/3 the dose, created an equivalent antibody response to the 30. And so they decided to study the 10, wanting to find the lowest effective dose. They then gave 1,500 kids from 5 to 11 the vaccine, and then they gave 750 kids a placebo, meaning they got a shot, but there was nothing in it. And they followed these kids to see what happens. In addition, they wanted to add a second level of safety, so they added another 1,500 for a total of 3,000 kids that got the vaccine and 1,500 that did not. And what they found was the immune response was similar between the 5 to 11-year-old group as to the 16 to 25-year-old group. And so the antibody response was the same. What they followed was they checked the kids when they got the vaccine and followed them for 7 days after. They checked them at when they got the second dose, followed them for 7 days after. They checked them at 1 month, and then they checked them again at 6 months. They also had a special attention of focus for MIS-C or myocarditis so that they could watch that carefully after the vaccine. And just for your comfort, I want you to show you that these two groups were very similar in their makeup. So there wasn't one group was healthy and the other group wasn't. What you can see from this is there was a basic distribution, an equal distribution between the participants that got the vaccine and those that got the placebo. So what happened after the kids got the vaccine? What you see in the top line is dose 1, and what you see in the bottom line is dose 2. What you see here is the 10 microgram dose. What you see here is the placebo. What you see here is the adult dose, or the 16 to 25-year-olds, and what you see is the placebo. So after dose 1, a little bit more kids get a little bit of redness, a little bit of swelling, and a lot of people get a little pain when they get a shot, not too surprising. So what about some of those more significant side effects that we all worried about? What you see here is the 5 to 11-year-old group, the 16 to 25-year-old group that got the vaccine, and down below, what you see is the reactions of people who got nothing. And you'll notice the green, the blue, the gray, and the red. The green is a very mild event or a mild fever. The blue is moderate. The severe represents those that had interference with daily activities, and the red represents those that had to seek care for the side effect. And what you'll notice is that the kids actually had lower rate of fever after the vaccine as compared to the older 16 to 25-year-olds. Some kids were a little fatigued, but less so than their counterparts. I always find it interesting in that the placebo group still reports about 25% fatigue after they got nothing, which makes me think that we're just a tired society, whether you're young or old. This has been very trying. But there was a little bit of headache, but there was even headache in the placebos. But what you'll notice consistently is with these 5 to 11-year-old group, they had less systemic side effects from the vaccine than the older other vaccine. And so this showed that the events were very, very mild and safe. A lot of people ask, what happens to people that had previous COVID? If your child had COVID, will they get worse symptoms after the vaccine? And fortunately, they studied this as well in dose 1 and dose 2. The positive represents those people that had, those kids that had previous COVID before they got the vaccine, and the negative represents those that didn't. And what you'll notice in dose 1, dose 2, is that in fact, if your child had COVID previously, their side effects weren't any worse after the vaccine. They actually may have been even a little bit less severe after the vaccine. And so if you're worried that your child previously had COVID, would they get worse side effects? The evidence would show probably not. Actually, maybe even less so. What about significant adverse events of special interest? Well, there was no anaphylaxis, no myocarditis, that's that heart inflammation, no Bell's palsy or facial paralysis, and no appendicitis. And so there was no significant adverse events in the intervention group, the group that got the vaccine. And so the safety conclusions of the 5 to 11-year-old group was the reactions after the shot were mild, short-lived, much like any other shots that we give. The worst is a little bit of redness or pain, and very rarely they got a fever. But in general, it was a lot less than the 16 to 25-year-old counterpart, and there were no significant adverse events. Now, some people might wonder, did they have as good of a response because they're getting the 10 microgram dose compared to the 30 microgram dose? And what this shows is the antibodies response. This is quantified, so how much antibody they got in response to the vaccine. So in all children, in the 5 to 6-year-old group, in the 7 to 8-year-old group, and in the 9 to 11-year-old group, they all had similar responses, and these responses were similar to the over 12-year-old group. This is probably the most important slide here, in that what you'll notice is the incidence of COVID-19, and this occurred during the Delta variant. In the group that got the vaccine, they had very, very few breakthrough cases, whereas in the placebo group, they had a lot, showing the vaccine was very effective. And this is where the conclusion is: the vaccine is 90% effective at preventing symptomatic COVID when you get it. And this effectiveness starts to work probably within about 12 days of getting the vaccine. And so when I think about that 12-day window when your kid becomes protected, and even more protected after the second dose, I think about Thanksgiving and Christmas. And I know we're all going to get together for Thanksgiving soon. And so we want to get these kids vaccinated, so when our families get together, they can be protected and not spread it to our loved ones. And so the question is, do the benefits of the vaccine outweigh the risks? And one of the biggest risks that I'm sure a lot of parents are thinking about is, some of us heard about this risk of myocarditis in older age adolescents and young adults, and would it occur in kids? Well, in the 3,000 kids that got the vaccine, there were no cases of myocarditis. And what we also know is that myocarditis is a unique illness, in that myocarditis, this heart inflammation, occurs outside of vaccines. People got myocarditis from infections, from viruses for years and years and years, but it had a propensity to inflict adolescents and young adults, especially males. So this was prior to the vaccine. This is classic myocarditis that occurs with a virus. And it used to always primarily affect adolescents and primarily males. And so they think that there's an effect of testosterone that attenuates or that amplifies myocarditis. And that's why we saw it in the young adults, adolescent males. And that's why we likely won't see it, or very little of it, in that 5 to 11-year-old group. The good news in the adolescent population that did get that myocarditis is it was very mild, short-lived, and without consequences. And when I think about myocarditis, one of the biggest muscles in your body is your heart. Your heart is just a muscle, it just pumps. And when we give a vaccine, we get muscle aches. So it's not surprising that some people got a little bit of a muscle ache in their heart that went away. It was really not considered life-threatening, and the kids recovered, or those adolescents, but it did not occur in the 5 to 11-year-old population. So the benefits for every 1 million doses of COVID vaccine in children 5 to 11 are thought to prevent 57,000 cases for the females, almost 57,000 for the males, about 200 hospitalizations, 130 cases of MIS-C, and 60 to 72 cases, depending if you're female or male, per 1 million doses delivered. So this vaccine will be very, very effective. There's huge benefits. So in summary, COVID-19 affects a lot of 5 to 11-year-olds. about 8,300 hospitalizations, 2,316 MIC cases in this age group, 94 deaths. And what we know from this vaccine trial that studied 3,000 kids who got the vaccine, that COVID-19, like all the other immunizations we give, is now generally considered a preventable disease. So should the COVID-19 vaccine be given to the 5 to 11-year-old age group? Well, COVID-19 is causing disease in children. COVID-19 is causing harm in children and adults. COVID-19 vaccine is very effective. COVID-19 vaccine is very well tolerated, very few or minimal side effects when you get it. The COVID vaccine is very safe, no serious adverse events. And as such, yes, the COVID vaccine for 5 to 11-year-olds is recommended. The benefits clearly outweigh the risks. So I appreciate everybody's time, and I really want to open this up for questions. Let's see if I can get my screen to fix here, and I'll open this back up. And I'll stop sharing. Let's see. No sharing. Okay. I think I'm good. All right. So hopefully we can have a dialogue. I want to open it up for any questions and see if it has any thoughts. And again, this was just information for you to make the best decision for your children.
Perfect. Thanks so much, Dr. Brooks, for doing all that research and putting it together in such a digestible way. And I can see, Marissa, thank you for jumping in on questions already. Yes, y'all should be able to see that the chat is open for questions. So Dr. Brooks, Marissa's question was just, could we get a copy of the presentation, if that's possible?
Yes, that would be absolutely possible. And I know that this was actually a very technical talk, but you guys as parents, I really want to be fully transparent, give you all the information so that you can make the best decision for you and your family, and hopefully can critically look at this information and decide, is this best for me?
Super helpful, Dr. Brooks. Yeah, and I was looking at the list of attendees, and I know that we have a really strong group of parents and staff joining us tonight that are really critical thinkers and paying attention to what's out there. So I really appreciate that you brought us that data, knowing that this is, yeah, you're right. This is a group that really is not afraid to lean into that. Okay, question from Natalie. Do you have data for hospitalizations from COVID in Colorado for children in this age group? Or do we have a sense of what that looks like more regionally?
You know, I participate regularly with a call from Children's Hospital, and they would have the majority of the data. I don't have it on the, I don't have it off the top of my head at this moment, but I'd be happy to send it to Anna. Let me actually quickly, let me look here really quick, because I might have it on my phone because I just, joined. Well, let me look for it, and I'll send it to everybody, and I'll see if I can get it from Children's Hospital.
Awesome.
As far as I can speak a little bit for our local hospital, and you know, as we've talked, this has been a disease that is primarily affected the older population. Children have been affected. We've had a few children hospitalized. We've had to transfer a few children for MISC. That has occurred over the last 18 months with us. And so we personally, as pediatricians in this area, have had to deal with some sick kids and some transfers to Children's Hospital, but I'll work on getting some of that information for you.
Awesome. Thanks, Dr. Brooks. Lauren's question was, will the recording be shared? You bet, Lauren. We will. That's part of why we've recorded it. So we'll get that shared out with families who weren't able to make it tonight. So yeah, absolutely. And just a reminder, if anyone has other questions, please put them in that chat box, and we'll give it a minute here if there's anything else.
So a lot of the concerns might be around myocarditis, and I think those would be excellent things to think about. And it's really hard because there's a lot of information out there. And is this going to impact my kid or not? And I think we were all really reassured by the 3,000 kids and not having any cases. We've also been really reassured about what has happened in those few cases, like the 1 in 20,000, the 1 in 50,000 of adolescents that did get myocarditis. And it was really a self-limited illness. And so we are not delivering this vaccine without the totality of the information that's being experienced. And currently in the United States, they've delivered 400 million doses of this vaccine. And I'm astonished about the safety data that is being monitored. We've all, or maybe most of us, have heard of something called the VAERS, or the Vaccine Adverse Event Reporting System. This is a system where all providers and all people can track any adverse events, and that's been monitoring any adverse events. There's something called the Vaccine Safety Data Link, where they proactively monitor about 10 million health records looking for any signal of any safety data. There is something called vSafe, which is an electronic app, and some of you may have had it when you had the vaccine, but that app has allowed the ability to monitor any side effects that maybe weren't picked up in the initial studies or in the surveillance. They have something called the Clinical Immunization Safety Assessment, where they're monitoring it. They have the Department of Defense monitoring it. They have the Indian Health Sciences monitoring it. They have the Veterans Affairs monitoring it. And so the safety and the monitoring that occurred with this vaccine has been nothing like any vaccine we've ever experienced. And so the safety signals, if there are any, have already been established. And so I think we have more data on this vaccine than we've had in any other vaccine ever.
Thanks, Dr. Brooks. For those who are watching and leaning in, I'm going to post a couple things. One is information about our upcoming COVID vaccine clinics at the Roaring Fork schools. I'm also going to add the link to the Valley View Hospital's COVID-19 vaccine clinics. So if you're trying to figure out where and how to get access to COVID vaccines, those links might be a great place to start for the Valley.
And we're doing at our office, we're doing vaccines from 2 to 5 p.m. every day this week. And on that link, you can sign up, and we've already delivered well over a few hundred vaccines. Other than a few screaming kids who don't want a needle, everything has gone very, very well, and you can sign up. People are getting through within, other than waiting for 15 minutes afterwards, they're getting through within 5 minutes because we have so many stations. And I think one of the most important things is to get your vaccine so that you get some of the effectiveness done early. I am worried about Thanksgiving in the state. Because I think what we're worried about is that's going to be another opportunity. And every time we've had a holiday, we've seen a bump in hospitalizations around the state. So as much protection we can get into kids as soon as possible will help mitigate that.
Dr. Brooks, we have a question from Brian. Are there any conditions or allergies in children that are of more concern to any potential side effects?
Yeah, good question, Brian. So if your child has a known allergy to one of the components, and the components are actually are not common allergies, but there's something called polyethylene glycol or polysoberate. Those are the two main things that could cause an allergy. So if your child has a known allergy to previous vaccines where they had anaphylaxis, meaning they had to get an epinephrine shot, then that would be a possible contraindication. And we'd want to talk to you about that. But the sign would be that your child has allergies to other medications that have PEG in it or to other vaccines. Very uncommon actually in children, but that would be the main thing to watch for. Now, there are some kids that are a little bit more allergenic. They have more tendency to have allergies. If your child has allergies to foods or other medications or other injectables, there's actually no problems in giving those vaccines, but we recommend a 30-minute observation period for those kids just in case. Now at Valley View, we've probably given 25,000 vaccines, and I have not really seen any serious allergic reactions in those 25,000 people. It is known that about 1 to 3% of adolescents and young adults will faint when they get a vaccine of any type, of any needle. And we have seen a few people faint when they see a needle. The ironic part is you actually don't see that very often in this age group. They sometimes scream, and maybe that screaming keeps their blood pressure up, but they don't tend to faint, but that's always possible. But that has nothing to do with the vaccine. That just has to do with some people are needle phobic and have this reaction.
Great. Thanks, Dr. Brooks. Let's give it another minute or so for any additional questions.
You know, some people ask about whether they should treat their kids with Tylenol or Motrin before they come in. And we actually don't recommend you doing that. Tylenol and Motrin help reduce inflammation or the inflammatory response. And a little bit when you're giving a vaccine, you actually want that to go on because that's your body reacting. You're kind of mimicking the inflammatory response, so you develop a whole bunch of antibodies. So it's okay to give Tylenol or Motrin that evening if your child's sore, if they have a fever, that's totally fine. But we actually don't want you to pre-treat with Tylenol, Motrin. And that's not just true for this vaccine, that's true for all vaccines, is that pre-treating is counterintuitive to the goal of the vaccine. Sometimes when people get fever or sore arm or some of those mild side effects that I mentioned, I actually often say, that's great. That means you got your money's worth. You got an immunologic response, and that's exactly what we want out of you. So to get some of those mild responses just means your immune system's working. When I got my booster shot, I had no response at all. My arm wasn't sore, and it made me think, am I sure they actually gave me one? And so I actually think sometimes when you get a little response, it's not a bad thing. It's a little bit of reassurance because you're getting your money's worth.
Dr. Brooks, I got a question today from a parent I hadn't even thought about yet, but should we be anticipating recommended boosters for this age group, 6 months? Do you think that's going to be a thing in your magic?
So that's going to be purely speculation on my part. In general, it's not unusual to have our immunity wane, whether it's through natural infection or immunizations. And given the infectivity and how transmissible COVID is, I would speculate that a booster is going to be needed because what we'll probably see is, and I actually am very encouraged. I'm thinking that in my mind, given some of the vaccine delivery, given how many people have had COVID, and given that the ammunition for this COVID to run its course is running out, that I'm thinking that this spring will really start to look better. In addition, you may have seen in the media that there are some better treatments coming out. Pfizer just released a new oral medication, Paxlovid, that will decrease hospitalizations in adults by about 80 to 90%. And so what I'm thinking is we're going to see the light at the end of the tunnel this spring, but it wouldn't surprise me if we see flare-ups on year after year, and that will trigger annual boosters like we get with the flu, and it'll become more of an endemic illness rather than a pandemic illness. That's pure speculation on my part.
Gotcha. Thank you. I have another question as a parent, Dr. Brooks. I know a lot of us are grappling with navigating kind of routine fall allergies and colds. And when, is there any concern? I mean, clearly, of course, we wouldn't bring a symptomatic kid that we think might have COVID to a clinic to get a vaccine. But if we know that a kid's got a cold or allergies, is there any reason to wait on their vaccine?
Yeah, no, that's a great question. Maybe when a lot of us were young, your doctor said, oh, if you're sick, don't get your vaccine. Well, that was a total myth. And there's absolutely no issues with giving a vaccine if you're sick. And so if you have a mild illness and it's not COVID, in fact, technically, you can give the vaccine if you have COVID, but we don't want you going out and being with the group of people. So for the isolation reasons, we wouldn't give it. But if your child has a mild illness, which we are seeing a ton of viral illnesses right now, there's no problems giving this vaccine. And in fact, we're seeing so many illnesses. It's actually, we're actually making up for last year because none of our kids were sick last year. And now we're seeing RSV, enterovirus, parainfluenza, adenovirus. And there's some concerns because they weren't sick last year. We're actually seeing a little bit more severity. And so having kids sick frequently is not bad. It's just not good to get a severe illness like COVID. And so there's no problems in getting it. Sometimes if a child has a moderate to severe illness, that may be a precaution to not give the vaccine. And when I talk about a moderate to severe illness, that your child is really sick, they might be in the hospital. And the only reason in those cases we don't want to give the vaccine is because we're dealing with already one illness. And so we don't want to get confused. Like if your child has pneumonia and we're trying to determine if the antibiotics are working, and suddenly we give them the vaccine and they spike a fever, and then we don't know, wow, do we have to take them to a CT to look at their pneumonia? Did that get worse, or was just the vaccine? So it just confuses the medical workup of a mild to severe illness, but it doesn't affect the effectiveness of the vaccine.
Gotcha. And Marissa has a follow-up question. How about, I imagine it's kind of similar question if kids have a cold, or I think maybe a second part of it is, could they do them at the same time? How about the flu vaccine?
Right.
Could they get the flu vaccine if they've got a cold, and then could they do it at the same time as the COVID?
Yeah, technically you can get a flu vaccine at the same time you get COVID. You can get your routine childhood immunizations at the same time. There's no contraindication to giving multiple vaccines at the same time. And when we talk about how our immune system is stimulated by vaccines, what really is important is how many antigens. The antigens are the immune stimulation that occurs with vaccines. And so COVID is really just adding one antigen, that spike protein, to our total protocol. And what's interesting to me is in 1980, when some of us as parents were alive and getting shots, when kids got their routine vaccinations, they covered about 7 diseases. But at that time, 40 years ago, there was about 15,000 antigens in those vaccines. Nowadays, in 2017, you get covered for 16 diseases, but you only have about 177 antigens. And so the vaccines are much more precise than they were 40 years ago. And so when we add the COVID vaccine, we're actually just adding another antigen. So our kids are actually getting, even with the COVID vaccine, they're getting way less immune stimulation today than they did in 1980, and much less in 1968 when I was born and I got a smallpox vaccine, because that vaccine had so many antigens it made people sick. And that's because we eliminated smallpox and it made people sick, we stopped using it.
Got it. Awesome. Thanks, Dr. Brooks. Any last words before we sign off?
I think the goal of this was just to give you good information. What you can see is the vaccine has been very well studied. It is very safe. I suspect of the population, and I don't know about the people on this call, but I suspect about 25 to 33% of the people, before we even gave this talk, they were going to go get the vaccine. It didn't matter. They were already bought in. There's probably another 25 to 33%, another third, that really need this additional information and are really just pausing to acquire more information so that they can make a great decision for those kids. And I hope if you're one of those on this call, I hope we accomplish that today. And then there's a third that I know that they've already decided they're not doing it right now. And I get it, and I'm okay with that. But what I hope is that they'll take some of this information, have an open mind, absorb it, continue to gather information. Feel free to reach out to your doctor, your primary care provider. I'm always willing to answer questions, even if you don't come from our practice and you just have a question about vaccines. I really want to be there for our community and answer those questions. So feel free to give me a call, and I'm happy to work through it. If you read something on Facebook, you get something from a friend, you have your Aunt Jenny who's telling you all sorts of things, and you really want to run it by somebody, I'm happy to discuss the pros and the cons and discuss it with you. And I hope those last thirds will consider the vaccine. So I hope you'll all reach out and get it done. We can put an end to this vaccine and get done with it.
Awesome. Dr. Brooks, thank you so much. And again, I know you spoke to the partnerships that have really solidified over the last 18 months. And we're so grateful for everything Valley View's done and support for the schools and school districts, and especially our kids and families. So thanks again for your time and expertise. Thank you all for tuning in, asking great questions. Thank you, Michael Mudd, for interpretation. And yeah, we'll get the recording out. So please share and reach out if you have any questions. So thanks so much, everybody. Good night.
Thank you. Thank you for your time.